I am Dr. Neeta Bhatnagar, the Principal Technical Advisor for Family Planning with the Momentum Country and Global Leadership. I am delighted to be here and thanks for having me. The topic for me is one of my favorites, orientation to the training resource package. Why I say it's my favorite is, like many of you, I have been a trainer for several decades. And every time I had to conduct a training, it was like a nightmare, burning the midnight oil to put the training materials together, to develop PowerPoint presentations, to ensure they are evidence-based. So now with the training resource package, and especially the TRP, which we lovingly call the training resource package, for family planning, training has become much more easier, and it is a joy to actually implement and evaluate a training. So my topic today is orientation to the training resource package, or the TRP. Next slide, please. So I would be presenting the background and overview of the TRP, the structure of the method-specific modules, navigating the site, which we'll do largely by the video, and I'm happy to take any questions and answers. Next, please. So the training resource package is a global resource package for trainers, supervisors, and program managers to support up-to-date training on family planning and reproductive health. It contains high-quality, evidence-based, user-friendly materials for designing, conducting, and evaluating family planning trainings. Next, please. Next, please. Let me give you a brief overview. Can you go to the previous slide? Yeah. So the training resource package was launched in 2012, led by USAID, WHO, and UNFPA, with participation from technical and training experts representing multiple trusted agencies and organizations. As I said earlier, it uses evidence-based technical information and under one roof houses the family planning curriculum, components, tools, and cross-cutting materials that trainers, supervisors, and managers actually need to design, implement, and evaluate the family planning reproductive health trainings. The best part about this training resource package is that needs of advanced providers, both for education. So when I say less to high level workers, you can adapt this for nurses, midwives, and clinicians, needs of your and level of your audience. From 2020 to 2022, USA country and global
Hello, Dr. Neeta.
TRP, use TRP as they're using the TRP to be mobile, accessible, and user-friendly. Next slide. Go to the next slide.
Now,
Connection. Next slide.
now it's okay, Doctor. Yeah. Now it's okay. Thank you so much.
Yeah. Can you go to the next slide? So the module content is continuously being updated. Previous slide. The previous slide. The module content is continuously being updated to align with global guidance, and newer modules are being added to align with the Global Family Planning Handbook. All the content is free of any copyright. You can use it as it is from the website or adapt it to your country context and the needs of the audience. The selected modules are available and being translated into French and Spanish. A new section is currently being developed as we are promoting a blended learning approach. So we are having a new section, likely it'll be in October, on guidance for facilitators on using these materials as a blended learning approach. Next slide, please. Next slide. Yeah. So the global good, this is a virtual platform. It's not a book. It's not a physical material. It's a virtual platform which enhances opportunities for health professionals and is adapted from global evidence, the cornerstone technical guidelines, the WHO Global Family Planning Handbook for Providers 2022, the medical eligibility criteria for contraceptive use, and the selected practice recommendation for contraceptive use. And the TRP incorporates all these competency-based training approaches and adult learning principles for adaptation to practice the context. Next, please. Let's go to the contents and features of the training resource package. Next, please. So broadly, there are two categories. One is cross-cutting and one is method-specific. The cross-cutting modules like counseling and the WHO guidelines and benefits of family planning, they apply to all the the method-specific modules. And the method-specific modules are categorized under permanent methods, which is female sterilization and male sterilization, the long-acting reversible contraceptives, like the IUDs and the implants, emergency contraceptives for pharmacists and providers, fertility-based awareness methods such as the standard days method and the lactational amenorrhea method, barrier methods such as the female condoms and the male condoms, and hormonal contraceptives, which include the oral contraceptives, the progesterone-only pills, progesterone-only injectables, and the vaginal ring. So these are the categories. These are the categories of the modules present. And each module has a method-specific facilitator's guide, which provides an overview of the materials in the module and how to use them effectively to conduct the training. Each module also contains a module session plan, which describes the subject content and instructions for the facilitator on how to use the content, the learning activities, the materials needed, and the resources. There are presentation slides which provide the technical content, right? The technical content of the method. And there are three types of slides. One is basic slides, which is applicable to all levels of the audience. It's the basic general characteristics, how to use it, when not to use it. The second type is the advanced slide, which may be applicable for advanced clinicians where you have some research studies, etc., and lots of data. And the third type is optional slides, which show that the procedure itself, So if under the job description, your attendee, your participant is not allowed to insert, say, an IUD, then you can leave that. So there are three types: basic, advanced, and optional. So based on the needs of your trainees and their scope of work, you can use these slides. We have a set of evaluation tools for evaluating the knowledge and
Dr. Neeta, I think we lost you. So sorry, dear attendees. We lost Dr. Neeta because of her interrupted connection. I think she is now joining back.
Yeah, I'm
Hello, Dr.
joining
Rita.
back. Then we have a
Yes,
series of handouts, which also have job aids on the methods, and they have tools like the comparing effectiveness of family planning methods, the medical eligibility criteria and wheel, the quick reference chart, the screening checklist, etc. We have a library of references. There are role play scenarios, case studies, the answer keys of which are in the facilitator's guide. And each module has a link to a video which can be shown. So every module includes all these materials. And very soon we are going to link to digital courses as soon as we get the blended learning materials and into the TRP. Next, please. So this is, when you open the home page, and we'll talk more about it in the video, and you click the training modules, so you'll get the library of the training modules. If you click the training guides on the upper tab, you'll come to the training guides. The community about TRP and their Next, please. Next, please. You still internet unstable. Next, please. Next, please. Okay, contraceptive implants. You'll get this page and you can just go to start preparing. We'll talk more about it when we show the video. Next, please. So yeah, now you have this, all the ingredients that a trainer needs to design their training material. You can pick and choose. It's like when you prepare a recipe, you have the ingredients. So you have all these ingredients based on their learning needs, based on the country context. You can pick and choose the materials and design your own training. Next, please. Next. Yeah. Next, please. Modules and resources can be downloadable and easily repurposed based on user needs. As you will see down, you will see that, for every resource, there are two things: view and download. It's applicable, download it, save it, and adapt it, change it, edit it, revise it. There is no copyright issue. You don't need anyone's permission. You can download it and modify it to the user needs and your country context, keeping the clinical materials, the clinical content as it is. Right. Next, please. Next, please. Yeah, so the the redesigned training resource package is optimized now for low resource settings with low internet bandwidth, as I'm facing right now. Improved accessibility You can use it on laptops, mobiles, and tablets. Hotspot. So there is a community section, which is a new section. And this allows when you we'll talk about it when you open this the community section, it will allow you to share your experience as trainers, south to south learning or otherwise, to share your experience, to ask questions, to post any resources that you have. So this is a very, very new and a very useful section which allows trainers to talk to each other and share their experiences. Next, please. Huh? Next, please. What's what? Okay. As I said, you can create your own account, and in the next slide, we'll show you how to save and arrange your resources as needed. Next, please. Let's see how you can create your account on the training resource package. Next. When you log on to www.fptraining.org in your chosen browser, you will see on the right side, next, please. You first log on to next. Select account in the top right corner, the one that is selected of the web page. Next, please. Use, if you're already a member, use your existing login information, or where the arrow is, if you want to create, see the red arrow. Next, please. Fill this text box, your first name, your last name, email ID, create your password and click create account. As soon as you do that, next, please. You will be prompted to check your email for a verification. There will be a link provided. Select the link and your account will be set up. You can try it. If you have any issues, we'll let you know whom to contact. Next, please. So try out the training resource package, join the community, be a part, join your other trainers, share your experiences, share resources, ask questions at www.fptraining.org. And for any questions, reach out to us at the following link. Next, please.
The Training Resource Package, or TRP, for family planning is designed to address the dynamic professional needs of health workers across all clinical and community-based cadres, and for adaptation and use for in-service and pre-service competency-based training. The TRP website first launched in 2012, led by USAID, the World Health Organization, and UNFPA, with participation from multiple agencies and organizations. It aims to equip trainers, clinical educators, and mentors with a library of high-quality materials derived from global family planning and reproductive health guidelines. The TRP uses evidence-based technical information and houses a clinical library of family planning curriculum, components, and tools needed to design, implement, and evaluate FP and RH training. All content is free of any copyright and can be used as is from the website by trainers, institutional educators, clinical preceptors, expert and technical advisors, supervisors within ministries of health, training consultants, and other program managers around the world. The content is continuously updated to align with revisions to global guidance. Modules on newer contraceptive methods will also be added. USA's Momentum Country and Global Leadership conducted extensive research with TRP users and experts from 2020 to 2022, building on landscape research and available user analytics to re-engineer and improve the functionality of the website platform, making it even more mobile accessible and user-friendly. As you navigate to About TRP, this section of the website provides an overview of the TRP, including its goal to equip trainers with easy-to-access and use training content for health workers. You can see its aim, statistics, and contributors. There are also references with links to the World Health Organization global guidance that informs all the content on the site worldwide. At the TRP's core is currently a collection of training modules featuring 4 cross-cutting and 15 contraceptive method-specific topics. These modules typically contain links to relevant videos, scenarios for role plays and case studies, sample lesson plans, presentation slides, pre- and post-test questions and skills assessment tools, handouts and job aids, and other valuable resources. These materials ensure interactive competency-based learner-centered training by trainers, mentors, or supervisors. In addition to modules, the TRP includes training guides to assist users with a library of general training resources, such as a facilitator's guide, an overview of adult learning techniques, options for icebreakers, a sample course evaluation, and additional links to other similar resources or packages for reference. A new feature in this redesigned TRP is the community page, which can be viewed by all. Members of the community can also create a profile to post announcements, share experiences, or ask questions of their peers in this global community of family planning trainers, educators, coaches, and mentors. Navigate to the account page to sign up to become a full member of the community and have a more personalized experience. You can create a profile and save and access favorite resources under the bookmark section. Let's see what a few users we met had to say about their experience of using the TRP website. It gives you an essence of belonging, essence of being able to identify and interact with the resource on a personal level. This would have a positive impact. The community forums are useful, as they allow all workers to share their experience on the ground, which in turn will inform trainers to update themselves on how things are actually progressing. The community section introduced here is excellent. People want to share and learn from experiences. Great to have this community platform. All downloads. I like this section. And how it has been named, clear to know that everything can be downloaded here in one go. Good to have the file type and size mentioned up front. Join the growing community and visit us at fptraining.org. Drop us a note about your experience at info@fptraining.org. The training
We would like to thank Dr. Neeta for a very informative presentation, and we would like to sincerely apologize to our attendees for the inconvenience in listening to the presentation because of the internet connection issues from the end of our speakers. But we believe that our webinar participants have learned the very useful training resource package for family planning and will make good use of these in designing, implementing, and evaluating your family planning trainings. And I think this 5-minute video clip also share the similar information which was shared by Dr. Neeta earlier. So for the second agenda item of today, I would like to introduce you with a brief biography of our speaker, Dr. Nancy Kidula. Dr. Nancy is an obstetrician gynecologist with over 30 years experience in clinical and public health. She is currently based at WHO headquarters, Sexual and Reproductive Health Department as medical officer in the Contraception and Fertility Care Unit. Dr. Nancy is currently overseeing the update of the contraceptive normative guidelines, namely the WHO Medical Eligibility Criteria, MAC for contraceptive use, the Selected Practice Recommendation, SPR for contraceptive use, and their derivative products and tools. Prior to this, Dr. Nancy worked in the WHO Afro Intercountry Office team for East and Southern Africa, where she supported countries to adapt, build capacity, and implement the WHO MEC and SPR. Some of our participants here might remember that Dr. Nancy also supported our webinar last year and shared the new updates from the WHO Family Planning Global Handbook for the providers. So with many thanks again for supporting our webinar this year also, may I cordially invite Dr. Nancy Kidula for sharing the WHO Medical Eligibility Criteria for contraceptive use and related MAC-WE and MAC application. Dear Dr. Nancy, the floor is yours.
Thank you so much. Allow me to share my screen. Okay, are you seeing the correct view, or you are seeing the presenter view?
Presenter view only, doctor. Not yet the correct view.
And now?
Now the correct view is here. Thank you so much.
Okay, thank you so much for this privilege of being with you in this meeting and sharing about the WHO medical eligibility criteria for contraceptive use, and then the derivative tools, which are the MAC-WIL and the MAC-AP. I will briefly give a short introduction, and then I'll give you an overview of the WHO medical eligibility criteria, contraceptive use, and then a little about the MAC-WIL and the MAC-AP, and then we will wait for the questions and clarification. So since 1994, we have WHO convening a body of international experts in family planning, and these include clinicians, program managers, scientists, epidemiologists, etc., to review the available evidence on safe use of contraceptive methods and organize the findings in a manner that can be used to determine a client's medical eligibility for a particular method. These recommendations of the expert review team are presented in the document Medical Eligibility Criteria for Contraceptive Use, or otherwise commonly known as MEC. This team of experts is convened every 5 years or so to review new research findings and to update the recommendations. And so we have two foundational normative products that guide the global contraceptive method safety and use based on evidence. And these are what you can see here as the medical eligibility criteria, now in its 5th edition, and what we call the selected practice recommendations, now in the 3rd edition. These two documents are currently undergoing an update. From these documents, we then get the derivative products, which are the FP Global Handbook for service providers and the decision-making tool. Now, these 4 documents that you can see here is what we refer to as the cornerstones of family planning. From these, we have now what we call derivative tools. The derivative tools include the MEC wheel, the MEC app, the FP DAX, and other tools that have been derived from these 2 main products to facilitate translation of the recommendations into practical guidance and to ease the provision of contraception. In other words, what we are saying is that the service provider does not really need to go through the MEC and the SPR. What we have done is distill what you have in these 2 main documents and then give you details in the handbook. If you are counseling, we have details in the decision-making tool. And then what you use when you are with the patient or with the client are either the DAC, the wheel, or the app for direct use when you are with the client. So we have today to discuss what we call the medical eligibility criteria for contraceptive use. The medical eligibility criteria provides guidance on whether a woman with specific medical condition or medically relevant physiological or personal characteristic can safely use a specific contraceptive method. So that is the most important thing, is safety, because when we talk to clients, their main problem is contraception, safe. And I am sure you have heard FP clients asking, will it affect my child? Will it affect my pressure? Will it affect my weight? So the issues that clients are very concerned about is safety. Is contraception safe? And this is what the MEC does. It tells you now, this is the condition of the patient or the medical characteristic of this patient. For this particular condition, is which contraceptive is safe. And in the MEC, we have more than 2,000 recommendations on eligibility for 26 methods of contraception. The MEC has been around. We have these 5 editions: 1996, 2000, 2004, 2009, 2015. And as we said before, we are updating it now to the 6th edition. So these are the kind of conditions that you will find the MEC addressing: a physiological status, either parity, breastfeeding. Those are physiological status, and you want to know, if I am nulliparous, which method is safe for me. There are groups with special needs like adolescents, perimenopausal. We want to know which methods are safe to use in this kind of groups. If you have a health problem, like if you have headache, irregular bleeding, if you have a non-pre-existing medical condition, hypertension, diabetes, heart disease, etc. So this is what will tell you which methods are safe to use in those conditions. So the MEC does not provide recommendation about specific brands, okay, specific products or brands to use after selecting a contraceptive method. So it will not tell you use microgynon, use this and that. No, we use the generic name or the generic group of products in the MEC. One of the things that is reiterated in the MEC is that family planning care must be delivered in accordance with the client's human and reproductive rights and is fundamental quality of care. And so the decisions about the family planning method choice should actually take into account not just clinical judgment, but also user preference. That's why we have a choice of methods that we offer. And then we will be able to tell the clients, this one is safe, this one is safe. Now, which one of the safe methods would you prefer to use in your particular condition and for the duration that you want? So these are the methods that are currently in the MEC 2015. In the update, I can say we have not added any new methods. So these are still going to be the methods that you'll find in the update. So what does categorization mean? What we do is that to determine the safety of a method, we categorize it from 1 to 4. And these categories indicate to us if a woman or a man for the male-directed method with a pre-existing medical condition or physiological condition can safely use a specific method. So we have 4 categories, as you can see. Category 1 means a condition for which there is no restriction for the use of the contraceptive method. So when we say that these conditions are category 1 for combined oral contraceptives, what we are saying is that in these conditions, there is no restriction for the use of combined oral contraceptives, etc. We have another category from that, which is category 2. In category 2, the advantages of using the method outweigh the theoretical or proven risk. I will repeat again because the problems we have are in category 2 and 3. In category 2, the advantages of using that method outweigh the risks. And that means the method can generally be used, but you need to follow up this client. So you can generally use the method. We have another category 3. Category 3, the risks, theoretical or proven risks, outweigh the advantages of using the method. And when we say that this method is category 3 for this condition, it means generally don't use this method if you have other methods that are category 1 or 2. To use a category 3 method requires careful clinical judgment. It requires access to clinical services for that woman, and you need to have to know the severity of the condition, the availability, practicality, and acceptability of alternative methods. So what we are saying is, if you reach a point where you are providing a patient with a client with a method that is category 3, it means you totally do not have any method available that is category 2. And it is imperative that this client is on a method, and therefore you are going to follow them very, very closely. You have to make sure they have access to clinical services in case they develop any complications related to that, to the use of that method. Why? Because the risks outweigh the benefits. In category 4, it means that the risk is unacceptable if the method is used. So if you see any method that is category 4 for a particular condition, it means it is so risky to use that method in that condition that you should not use that method at all. So those are the 4 categories. Category 1, you can use unrestricted. Category 4, do not use this method in this particular condition. And then we have category 2 and 3 in the middle. Category 2, you can generally use the method because the advantages outweigh the risks. And category 3 is the theoretical or proven risks outweigh the advantages of the method. And so in summary, we have this lower table, category 1 and 2, you can generally use the method. Category 3 and 4 generally do not use the method. So this is very important for you to come out from this webinar with. When we do the MEC, if you read the mother document, you are going to have things like this kind of presentation where we give you the conditions. Like now we have pregnancy here, and you can see it's NA, because we don't expect someone to be using contraception when they are already pregnant. That is why it's said not applicable. But with all this, we will always have what we call a clarification, okay? The clarification gives you additional information that you need to know about the MEC categorization and what was the basis for that categorization, and to clarify issues that are generally asked by the users. And you will find this clarification on the evidence column for each condition. We also have this rider in all methods that they do not protect against STIs and HIV, etc., and the recommendation for correct and consistent use of condom for protection against STIs and HIV while providing contraceptive benefit. I will not go through this because of time, but you can read it. The importance of adequate information to help the client make informed, voluntary choice of a contraceptive method. So, as the health provider, what we have done is distill the big document and put it into small, user-friendly tools that you can use when you are with the client. And one of them is the wheel. Now, the wheel does not have all the conditions that are in the MEC document. The wheel basically has common conditions that have been expressed by a lot of member states, and we have put them on the wheel. There are other conditions that you can find the categorization in the main document. So don't just look at the wheel and say, this thing is not there, WHO, what is happening? Go to the main document, you are likely to find the condition there. And it gives you recommendations for these methods. And I will show you where conditions that are category 1 and 2 for all methods appear, and there are additional explanations. And then what you do, you locate the condition of interest. The conditions are here on the outermost perimeter, and the next one is the sub conditions, and then you have the contraceptive methods, and then you have the categorization that you will see in the small window of the smaller wheel. So this is what it looks like. From the onset, I would like to say, when we talk about the MEC wheel tool, this is not the tool. The tool comprises of the wheel and the jacket. So when you are using the MEC wheel tool, you need to have both the wheel and the jacket, because there's information on the jacket that is important, and there are conditions like emergency contraceptive pills that are reflected on the jacket and not on the wheel. So when we take the wheel, you have the smaller wheel. The smaller wheel is the one that has the methods, and it has this window that you will be able to look at to see the categorization. It also gives you a summary of the MEC categorization here. It gives you which edition of the wheel it is. Currently, you must make sure you are using the 2015 edition of the wheel. We have gone to facilities, there are people still using the 2004. So the valid wheel at the moment is the 2015 wheel. And then we have information here about the risk of HIV protection and the use of condom. So you have the smaller wheel, and it is superimposed on the larger wheel that has the conditions and the sub-conditions. When you go to the back of the wheel, which is this one, you will have additional instructions. So these are additional instructions. So you may find that here you have 4 and there's a superscript D. When you see that superscript, turn on the back of the wheel, look for D, and it will give you that additional information that was indicated by the superscript. The superscript are on the categorization. So when you see a superscript, you turn the wheel, you look here on the additional information, and it tells you what that superscript means. Lower down here, you will find conditions that are category 1 and 2 for all methods. Sometimes people tell us, no, I cannot see this, I cannot see this. Turn on the back of the wheel. Maybe that condition is category 1 and 2 for all methods. For instance, you can see adolescents here. It means contraception used for all methods is category 1 and 2 for all methods. So there are conditions that you are going to find on the back here that you can generally use all methods. So how is the wheel organized? You can see these are the selected methods. That's where you get them. These are the health conditions, as we said, on the perimeter of the larger wheel. And this is the MEC category. That is what you will see when you move the smaller wheel over the larger wheel and you see the numbers. The numbers denote the MEC category. And as we discussed, when you see a superscript, a small letter on top of the number, turn to the back of the wheel, look for that letter, and you'll get the additional comments on the back of the wheel. Now, this is the jacket. As you can see, the jacket, even if we ignore all this, you can see it gives you information on how to use the wheel. And if you turn it inside, it tells you about the wheel. It tells you which methods are in the wheel. It gives you the abbreviations for the ARVs. It gives you the MEC categorization for emergency contraceptives, whether they are the emergency contraceptive pills or the copper IUD for emergency contraception. And that is why we say the wheel, the tool is the wheel and the jacket. I will not go through the practice, but I have some exercises here for you, which you can practice later by yourself and see. You read the whole history. That is why you take history in a family planning consultation. You have this 24-year-old. So the moment you see 24-year-old, you know this one is not an adolescent. So you are not going to be looking for adolescent. She has delivered, you know this lady is postpartum, okay? And she's 6 weeks. You can see she's postpartum and breastfeeding. So you can actually look for the condition of postpartum and breastfeeding. We are seeing she would like to space her next birth by 3 years. So in your mind, you are thinking 3 years is quite a long time. So she probably may want a long-acting method for convenience. But you have more stories here. She has a history of hypertension during pregnancy, a history of hypertension. So you have to triangulate all this and you put in the wheel, postpartum and breastfeeding, okay? And then history of hypertension during pregnancy. What you need to remember is that when you have more than one condition, the categorization that you are going to use is the largest categorization, the condition that will have the biggest number. For instance, if we say that she's 6 weeks postpartum and breastfeeding, and she wants combined oral contraceptives. You will look and you will see COCs at 6 weeks is probably category 3. And maybe history of hypertension during pregnancy may be category 2. So it means that you'll take the bigger number. The bigger number, the higher categorization is what will be the overall categorization that you are going to select. So keep that in mind because we are looking at oral contraceptive methods. There is another example for you. So this is what you will explain to you. So the question was, is she eligible for oral contraceptive methods? Remember, oral contraceptive methods, we have progesterone-only pills and we have combined oral contraception. So when you look at that, you'll see breastfeeding, category 2 for POPs from delivery, but COCs is category 4 at less than 6 weeks and category 3 through more than through 6 weeks to 6 months. So you have to think about that and put it there so we can see you cannot offer them combined oral contraceptives, but you may offer them progesterone-only pills. But at the same time, you are looking in that window to see, is there any method that is category 1? Because category 1 method should always be your first choice. And you are going to tell this client, okay, this is what we have. You would like contraceptive pills. Yes, we may give you progesterone-only pills. You have information on effectiveness. You have information on adherence. Discuss with them. And you may be able to say, now, when we look at the other methods, we can offer you this one. We can offer you this one. We can offer you this one. Which one of these would you prefer vis-a-vis the advantages and the disadvantages of the method? Now, going quickly to the app. The app is called the WHO Contraceptive Tool. It is the digital version of the wheel, and it contains almost the same things. So in addition to looking at individual medical conditions or characteristics, it's easy in the app to combine multiple conditions or characteristics. So for the wheel, you have to turn to this condition and then see what is the categorization for this condition. Then you have to turn to the other one and see the categorization. But in the app, you can put all those conditions together in one, and then it will give you that categorization that you need, taking cognizance of everything. We are trying to upload the Burmese app. We are having a few issues with the developers, but we are following up and we'll soon have it up and running. So we hope you have downloaded the app. And the question was, you have a 40-year-old woman with migraine headache without aura. So we have the condition is migraine headache without aura. And we have other things that you need to put in the calculation. She wants privacy. She doesn't want everybody knowing which methods that she is using. So these are very good and easy to use the app. So the app comes like this. This first one here is the landing page. The landing page gives you all these options. You will have the eligibility tool, the methods, any additional information, how to use the tool, about the app and feedback. And with the languages, you will all usually find the language here at the bottom here, and you can select the language. So once you go on the eligibility tool, it gives you all the different conditions, and what you want is migraine and aura, or in this case, you have this lady who was having diabetes. It was not in the history. She has diabetes as well. So you can see under diabetes, you have all different things. You have nephropathy here, select. And at the bottom, you can already see the recommendations. It will always give you the recommendations at the bottom. So you can already see Copper IUD is category 1, POP is category 2, CHC is category 3. So here you can already see. If you add another condition, you have migraine without aura and a headache. You can already see the categorization here for migraine and migraine with aura. From this space, you can continue to preferences, or you can continue to more recommendations, and it will give you basically what you are seeing here. Now, one other thing is privacy. Privacy is here under additional information, and you can see if you click privacy, it gives you which methods will give you more privacy. You can see privacy is there with the copper IUD and so on and so forth. So when you go to the methods, you have this method shows you the copper IUD privacy. Levonorgestrel IUD, you'll be private. POPs, you don't have privacy. You see? So it shows you now this person wants privacy. These are the methods that you can see according to the MEC categorization. And these are the ones that will give you privacy or whatever other thing you are screaming for. And if you want more information, you can actually click here on each method and it gives you more information. The app also have this effectiveness chart, which we are updating actually in the current update. We are going to be updating the effectiveness chart, but for the moment you can use it as it is. So in conclusion, what are we saying? We have this WHO medical eligibility criteria that addresses a very important factor in contraception, which is safety of different contraceptive methods when used by women of reproductive age with different medical conditions or physiological characteristics. What is that telling us? It means that even if a woman has a certain medical condition, it is possible to be able to find which contraceptive method is safe for them to use if they have that particular condition. And even if they have multiple comorbidities, you can triangulate and you should be able to at least get a method that they can generally use. The MEC wheel and app are derivative tools. These ones, you use them when you are face-to-face with the client to facilitate your decision-making and to even show the client and explain to them the different methods so that they can be able to choose the method that is the safest for them to use at that time. And as we said, we are currently updating the 6th edition we are writing now, and this one should be out by Q3 2025. So we want to thank the organizers, and we'll be on standby for any questions. Back to you.
Thank you so much, Dr. Nancy, for sharing these very practical information and tools. We hope our webinar attendees will be using more of these apps and wheels in their family planning service provision and counseling. We have shared these tools in our webinar invitation earlier. So, and after the webinar also, we will again share the technical notes and all these materials to all the attendees. Thank you, Dr. Nancy. So for the last part of our today's presentation, we will introduce you with a brief biography of our speaker, Dr. Rita Kabra. Dr. Rita Kabra is a medical doctor with expertise in reproductive health and public health management, and has over 30 years of work experience, including 20 years at WHO headquarters in Geneva, in clinical practice, research, development of norms and guidelines, and implementation of evidence-based practices in the field of sexual and reproductive health and public health with a focus on family planning. Currently, Dr. Rita works at the Contraception Fertility Care Unit in the Department of Sexual and Reproductive Health and Research at WHO Geneva. She leads the work on building country capacity in programming, supporting post-pregnancy family planning, South-South learning exchange, and is the project manager for the WHO Family Planning Accelerator Plus project that aims to improve access to quality and right-based family planning services. So with help her, thanks for agreeing to support us for today's webinar. I would like to invite Dr. Rita Kabra to kindly share us the WHO guidance and tools on post-pregnancy family planning. Dear Dr. Rita, the floor is yours now. Dr. Rita, can you hear us, please?
Yes, I can.
Okay.
Thank you so much. And let's see if I can share my slides from here.
Yes, Doctor.
Is it happening? Let me know when you can see.
Okay. We can see the screen now, Doctor.
Is it in the right mode?
Now it is in the right mode. Thank you so much. Over to you.
Thank you so much. I'm so happy to be here and on this webinar. Thank you so much for inviting me. Myanmar has always been a favorite country to work with. So I'm very happy to be here today. So what we're going to talk today would be more about the guidance and tools on post-pregnancy family planning and contraceptives which can be used during post-pregnancy family planning. But before I go into this, let me just say what is post-pregnancy family planning. So post-pregnancy family planning refers to both postpartum and post-abortion family planning. So we refer to postpartum as prevention of unintended and closely spaced pregnancies throughout the first 12 months following childbirth. This includes both immediate, extended, and different terminologies have been used, but it is actually preventing closely spaced pregnancies following a childbirth. And when we talk about post-abortion family planning, it refers to prevention of unintended pregnancies following an abortion. Sometimes this abortion could be in the form of an ectopic, it could be in the form of gestational trophoblastic, it could be a missed abortion, but whatever kind of abortion is, if we want to prevent an unintended pregnancy following an abortion, it comes under post-abortion family planning. I think these two are very important, both post-abortion and postpartum. And we know that family planning as such can avert more than 30% of maternal deaths. And it can avert about 10% of child mortality if couples space their pregnancy for more than 2 years apart. And to space their pregnancy, they would need to use the contraception. Evidence shows that short birth intervals increase the risk of both adverse maternal and infant outcomes, such as they result into low birth weight, increase infant mortality, and hence we need to avoid those. Similarly, if you look into abortion, using an modern contraceptive method, it may prevent up to 90% of abortion-related mortalities, which may be because of unintended pregnancies. And in many situations, we have seen, especially when abortion is happening in a facility, that 3 out of 4 women are leaving the facility without a contraceptives. Thus, they are putting themselves at increased risk of unwanted pregnancies. Post-abortion family planning reduces this unplanned pregnancies and repeat abortion. Our aim is here that, okay, even if we have not been able to prevent the first abortion, let us at least make efforts to not have the second. Having said all this, we also know that a lot of abortions, especially the medical abortions, are happening outside, but we should not miss any women, at least, who is coming to the facility for an abortion to go through it again. This is just to say, why do we want to accelerate, why we are focusing so much on post-pregnancy family planning. We know that 65% of women who have delivered want to avoid or delay pregnancy, but still many of them are not using contraceptions. At the same time, we also know that in most of the countries, institutional deliveries are on a rise. There is high antenatal care coverage, and this offers opportunities to provide family planning services to all those who need it. Similarly, following an induced or spontaneous abortion, ovulation may occur as early as 8 to 10 days, and sometimes within 1 month. So there are many issues, and we know that women, even who are not fully breastfeeding, may become pregnant within 4 to 6 weeks. And we also have safe and effective contraceptives available. So when we know that fertility can happen, we know that sexual intercourses occur earlier, we know that contraceptives are available, why not we make sure that we use it and accordingly decrease mortality, morbidity, provide more opportunities to women to have their comfortable sexual life. I'm not going to go again into the details because you just heard most of the contraceptives, which are most of the WHO guidelines on family planning. Currently, there is no specific guideline on post-pregnancy family planning. We have two set of guidelines, and you will see this is a set of guidelines which we just talked about: the medical eligibility criteria, the selected practice recommendation, the handbook, the Mac wheel, the mobile app. We were just, my colleague Nancy had explained to you about this. And these guidelines are the ones which have recommendations for both postpartum and post-abortion family planning. In addition, you will see we have other guidelines. This is a whole set of guidelines which talks about abortion care, and we talk about comprehensive abortion care guidelines. And we have about a toolkit, which is also talking about how we can strengthen the primary health care worker. This is more to talk about competencies and development of curriculum. We have one guideline here which talks about the programming strategies for postpartum family planning. And again, it is only focused on postpartum, and I'll come back on this, but it's a very good guidance document. Apparently, it was established, it was developed in 2013, or maybe even earlier, 2011, and needs to be updated. We also have many guidelines which we call as the program implementation guide. So these are the guides which help us in implementing a program and scaling up. And these are more guidelines which are focusing on how do we scale up. Then we have the digital adaptation kit, which is also talking about family planning. You already heard about the training resource package, a very useful tool from my colleague, Dr. Neeta Bhatnagar today, who talked about how we could use this into training healthcare workers. We have guidelines on, which you can see here, which is on task sharing, showing how we could use health workers and how we could share tasks between health workers in order to fill up our paucity of health workers working in countries. So how we could use more of our community health workers to do more counseling and to provide contraceptives which they could provide, which they are eligible or which legally they can provide. We have a guideline which is called on documenting best practices. And this is again a very useful guide, especially useful in countries where people are still shy of documenting their work. And so this guidance is very helpful to do that. And unless we document what we are doing, it's very difficult for good practices or even bad practices to be known. So since we have a wealth of experience at country level, we would really recommend using this documenting best practice guide and start documenting your practices. In family planning, whether it is post-pregnancy, postpartum, post-abortion, services are always provided to ensure human rights and quality of care is kept in mind. And so we very much use this quality of care guidance to make sure that our services are up to date and to the mark, and they are addressing to all these issues of non-discrimination, of making sure that services are available, accessible, adaptable to the people, of helping women and couples to make an informed decision-making, ensuring privacy and confidentiality and accountability. So in order to this program, we could use these guidelines. This is the new guidance or an online training tool which has been developed in collaboration with the WHO Academy. And it refers to postpartum family planning counseling. And you know that counseling is very important during postpartum, during post-abortion. So throughout the period, whenever a woman needs a contraceptive, and I think this was also iterated by the previous speaker, that counseling is very important. We need to really make sure that we advise the women on what are the different contraceptives available, what are their side effects, what are their efficacy, and how they can be used, so that an informed choice is made. So this family planning counseling tool has been developed. It's a hybrid tool and is available online, and we can share with you the link. All providers can go and they could do this course. It will really help you to improve your skills on counseling. And this is what I was saying. This is the first time, this is a guidance tool we are developing. And it is the first time we have brought together post-abortion and post-pregnancy family planning together, as well as approaches used for scaling up. We hope that by early 2025, we are able to develop this tool and bring it to countries. So as we have been talking about post-abortion and postpartum family planning, I would just show you that these two are being put together because we find that they are very similar, but at the same time, we find that there are some differences, and it's very important to keep these similarities and differences in mind. What is similar between the two? The two, both post-abortion and postpartum, both of these interventions are based, the purpose of both is to prevent unintended pregnancies and to reduce maternal mortality and morbidity. And in both the conditions, we are trying to empower the women to make an informed choice regarding if and how and when to have children. Both are based on evidence-based interventions, and these are based on our guidance. So whether you're doing post-abortion, post-contraceptive, the contraceptives are same, the providers are same, both need high level of leadership and governance, both are based on health and human rights principles, and both respect voluntary counseling and information. So the provision is same. But in order to have post-abortion and postpartum family planning, we really need a strong health systems. We need to make sure services are available, affordable, accessible. Both are influenced by religious and social norms. For both, we have to have adolescent and young youth engaged in doing it. And these services should be available at all the level of service, healthcare. It should not only be limited to primary healthcare or tertiary healthcare, but they are required at all the levels, because in real practice, women with abortion or women with even deliver at different level of health facilities, and hence these services should be available at all the levels. But remember, there is also a very big difference, and this needs to be kept in mind whenever we are talking about this. We have enough windows of opportunity for counseling postpartum family planning, and we should not miss them. Because when we're in contact with the women many times during antenatal, during childbirth, postpartum, we can counsel them on the importance of using contraception, so that when they come in the postpartum period, they are ready. However, when it comes to abortion, we have limited opportunities because it's not such a long time. And hence, as the facility touch points are fewer, many of the abortions are happening outside. We should try not to miss anyone anytime. The aim is to offer all women at the same place and the time when they receive an abortion or they happen, whenever we get to meet them, we should offer them the post-abortion care services, which includes post-abortion contraceptive. These are other differences which you see in between the two, that there are restricted policies which are preventing post-abortion family planning. Post-abortion is happening outside, and social religious norms are more stronger and preventing women, and there is a stigma associated with abortion, which we do not see so much in post-pregnancy family planning. So in a nutshell, both the issues have similarity and differences, but here the aim of both is women should be empowered, informed choice, and choice depends on her values and preferences. It's women's wishes and her future plans for childbearing which is important. What is the intent of pregnancy is important. So we need to keep this in consideration when we are trying to talk about post-abortion. So I will just go a little, I know we are running out of time, but I wanted to talk a little about the contraceptives which can be used during post-pregnancy family planning. And these are the list of the contraceptives which are available in our handbook and other guidance document, which shows us the effectiveness of contraceptives. And almost all contraceptives can be used in post-pregnancy period. There is some differences in this, and this is another chart which we have made, which shows that all women in the postpartum period up to 12 months and beyond can use progesterone-only implants. But when it comes to IUD, which is copper or hormonal, remember they can be given up to 48 hours, but we don't have enough guidance, and so we prefer that they are not given between 48 hours to 4 weeks. And then again, it can be given anytime. Similarly, for female sterilization, it is preferable, okay, up to 2 to 3 days we can do, but after that, we do not recommend female sterilization. It should only be done after 6 weeks. Male sterilization, the progesterone-only pills, the condoms, spermicides can be used by any women at all the time. If the women wants to use a diaphragm or cervical cap, it is recommended to be used only after 6 weeks. And then we also have lactational amenorrhea, which is the women some women are breastfeeding and they do not want to use any of these contraceptives. They only want to have lactational amenorrhea. They can continue it up to 6 months, provided they are using it fully and they are exclusively, otherwise there may be chances. And I have a slide to talk more about this. When it comes to progesterone-only injections, we prefer that they be used by women only after 6 weeks. Now, combined hormonal methods are a no because of the risk of VT, and so it is only preferred and it is actually only given to women after 6 months. And then we have also categorized them as the women who are non-breastfeeding. And there's a little difference here. The women who are non-breastfeeding, they can have a progesterone-only injections right after the delivery. And for combined hormonal methods, it is said that they can start it as early as 3 weeks or 21 days. So you can see slight differences in the timing of starting the contraception following a delivery. And my colleague had just explained you about the MEC criteria of 1, 2, and 3. So I will not go into details, but I just wanted to show you that accordingly, we look into whether women can use a POP or a DMPA or an implant. And these are the categories which we need to do, which we need to consider when we are implementing these contraceptions. However, as the first slide actually explained us what all contraceptions that can be used. Similarly, for the combined oral contraceptives, you will see that where the category is 4, it should not be there. So if a woman is breastfeeding and she's less than 6 weeks, as earlier said, the category is 4, so she should not be given combined oral contraceptives. Only a woman who is breastfeeding more than 6 months, when the category is 2, and if she doesn't like any other contraceptives, and if she's not eligible for any other, we could give them combined oral contraceptives. Similarly, for IUD, which is again very much used by postpartum women, and it could be a levonorgestrel IUD, it could be a copper IUDs. These are also very good and long-acting reversible contraceptives. And the recent studies have shown that a copper T IUD can be kept for 12 years, and an LNG IUD can be kept for 7 years. And as I said earlier, these IUDs can be inserted either within 48 hours or later. This is what I was saying, that if a woman on the postpartum period adopts lactational amenorrhea, she can do this for up to 6 months, but she should meet 3 conditions. And these 3 conditions are that mother's monthly bleeding is not returned, baby is fully or nearly fully breastfed, and that means that the baby is fed often day and night. And night is very important. It's not only day, but day and night. And baby is less than 6 months old. And once the woman is, or the baby has crossed 6 months, women should be offered another method, because then LAM is no more effective. When we come to post-abortion family planning, again, all the contraceptives which we just mentioned, these can be used after an abortion. Important again here is that women should be counseled immediately after, for post-abortion contraceptives. having counseling it, women should only use them, or the provider should not, there should be no coercion. We should know what is the intent, why the abortion happened, and does she really want it or not. So it should be the choice of the women to use the contraception, but all contraceptives will be considered after abortion. And I'm going to share these slides with you, but you can see that an IUD can be inserted anytime after the first abortion. It can be inserted successfully at the time abortion is happening. If it is a second trimester abortion, again, you can insert it at the time of abortion. But insertion must be done by a trained person. If women have had any infection or they did septic abortion, IUD should not be inserted. So these are some of the things we need to consider when we are offering women contraceptives after abortion. Similarly, there are implant POPs, COCs, and all the different hormones the women can start immediately after abortion if she has had within the first and second trimester. Even if she has done a medical abortion, she can start anything immediately. And here, self-administration of injection can be considered if they are available. So these are some of the ways, and we could see which women could use which contraceptive at which time. But remember always that clients' wishes and our future plans are most important. And these are some of the additional considerations which need to be given. So for example, if a woman has chosen a pill, we can give him up to 1 year of pills at one go. And we inform the women what are some of the complications or what are some of the issues she could have if she is having an abortion, but at the same time, how she could come back, and there should be good counseling after giving any contraceptives. So I know the time is up, so I'm going to stop here, but this is a link on which all guidance on the WHO will be available. Thank you so much.